Hello everyone, my name is Dave Anantrach and this presentation is for the course MRM 5013 Research Methodology Assessment 2. Today I'll be presenting my proposed research titled Predicting Diabetic Retinopathy Incidence Within 1 to 3 Years Using Electronic Health Records in Singapore. In this presentation, I'll cover the study background, research objectives, methodology, model development and validation, ethical considerations, and conclude with a summary and references. So, diabetes continues to rise globally according to the International Diabetes Federation. And one of the complications of diabetes is diabetic retinopathy, hereon as referred to as DR. So, DR is a leading cause of preventable vision loss among working age adults. So in Singapore, there's 1 in 10 adults who are at risk of vision-threatening diabetic retinopathy. So how Singapore screens diabetes patients for DR is through an annual retinal screening program, which is known as the Singapore Integrated Retinopathy Program, SIDRP. And according to Nguyen et al., a lifetime screening cost for a single patient under the SIDRP model is approximately 2,000 Sing dollars. Now, though the SIDRP detects existing DR with a 90% sensitivity, it does not predict risk of new onset DR for a patient within the next 1 to 3 years. So herein lies the research gap. There is limited risk stratification and this may delay early intervention. And there is a benefit to designing a predictive model that can guide targeted screening and efficient resource use. So this study has 3 main research objectives. The first objective is to identify demographic, clinical, and treatment-related factors associated with the incidence of DR within 1 to 3 years among adults with type 2 diabetes who did not have retinopathy at baseline. And the second objective is to develop an internally validated predictive model using the EHR records to estimate the individual's risk of developing diabetic retinopathy within the next 1 to 3 years. The model performance will be assessed using metrics such as AUROC, sensitivity, and specificity. And finally, the third objective is to translate this predictive model into an interpretable risk score, which can classify the patients into risk tiers and evaluate how this risk stratification could be used in practice to prioritize screening or early intervention. So this study adopts a quantitative research approach as it focuses on the analysis of numerical clinical data such as HbA1c levels, blood pressure readings, lab values, and medication records. This is a retrospective cohort design, so patients without diabetic retinopathy are selected at baseline and then followed using historical electronic health records over a 1 to 3 year period to observe incident retinopathy. So this design is well suited for incidence prediction because it allows the use of existing longitudinal data and it does not need any effort to collect new data. As the study relies on secondary AHR, the data has already been collected by the Singapore Public Healthcare, so we are using this to do new research on it. So this enables large-scale, cost-effective analysis and it already provides strong external validity. Overall, this is a retrospective, observational, predictive cohort study. So this slide is important. It illustrates the study timeline. So the electronic health records are accessed from 1st January 2021 to 31st December 2025, and we kept the baseline of these patients between January 2022 to December 2022, so we can have a sufficient prediction window for 1 to 3 years up to 2025. So when we establish patients with eligible baseline, which is the visit with no recorded DR, we look back in a period of 12 months and get all the variables and the information from all the relevant variables, and then we have a prediction window which is 1 to 3 years, and the outcome would be the first confirmed DR event in the SIDRP registry, or maybe they don't develop DR in the next 3 years. So for example, a patient ABC attends screening in January 2022. the result is no DR. So we look back in the period of January 2021 to December 2021, and we see that the patient has a HbA1c value of 8.2%, his blood pressure reading is so, he's on insulin, and there was 5 clinic visits within that particular period. And then we follow him for the next 1 to 3 years from the baseline to see whether there's any incidence of DR. And the outcome would be, if there is any incidence in the DR in the 3 years, we take that as a yes, and if there was no development of any DR, and then we record it as a no. So for objective 1, the aim was to identify factors associated with the incidence of diabetic retinopathy. A quantitative deductive approach is used to employ using statistical model techniques such as regression analysis and feature important analysis. So this deductive approach, it allows the study to test whether the established risk factors of diabetes, so we've already established that HbA1c, blood pressure, and albuminuria, according to Tsui et al., is established risk factors for diabetes. So whether they are also predictive of diabetic retinopathy in the Singapore population. So in doing so, this study verifies the existing theoretical evidence of diabetic risk factors within a local healthcare context, and whether or not these risk factors are relevant to retinopathy. So when it comes to feature importance, it helps us understand which variables in the model contribute most strongly to the prediction power. So we can identify this using feature important methods. So I've selected two methods that are model agnostic. So one of it is permutation importance, which measures how much a model performance decreases when the values of a feature are randomly shuffled or dropped. So there is any feature that is more important would be causing larger drops in the model's performance, according to Wang et al. In addition, Sharpe values or Shapley additive explanations, they are also used to quantify each feature's contribution to the individual predictions. So the benefit of Sharpe is it gives both a global importance and also a local importance of a certain variable. Local importance meaning predictions at the patient level. Now objective 2 focuses on developing and validating the predictive model. So we use a inductive supervised machine learning method using models such as logistic regression, random forest, and XGBoost. Techniques used here are also internal validation and cross-validation. The machine learning model technique is appropriate here because the risk of diabetic retinopathy DR is influenced by complex and potentially non-linear interactions between the variables, which traditional regression models may not fully capture. So these methods, according to Raj Kumar et al. And Shikel et al., they have been shown to perform well in the clinical prediction task involving large-scale EHR data. So how do we validate these models? So there's internal validation and cross-validation. So internal validation includes testing the model on a test set which the model has not seen before during its training phase. And cross-validation is when I selected k-fold cross-validation here. So it splits the data set into for certain subsets, for example 5 subsets. So if we have 5 subsets, the model trains on 4 subsets and then tests on the 5th subset. And then it does this 5 times, replacing the test set with a different set from the previous training set each time. And once it has 5 results, it averages the results. And by doing this cross-validation, it reduces the overfitting and also provides a robust estimate of the model performance. Now, the performance of these models are evaluated using metrics such as AUROC, area under the receiving operator curve, sensitivity, specificity, and calibration plots. So AUROC measures how well the model can distinguish between in this setting is patients who will and will not develop diabetic retinopathy. So if there's a higher value of the AUROC, there's a better discriminating power of the model. And sensitivity is the proportion of future retinopathy cases correctly identified, and specificity is the proportion of non-cases that were correctly identified. So objective 3 comes to translating this predictive model into a clinically interpretable risk score. So we used a deductive approach to convert the predictive probabilities into meaningful risk tiers such as low, medium and high risk. So this supports a practical implementation in real-world screening programs. It allows clinicians to prioritize patients on a risk level. I will go on how we identify the threshold in the next slide. So the threshold, how do we tell what is the point that we say, oh, this is low risk or this is high risk? So I'm using something called Incidence index. So Incidence index, what it does is, if you see the chart here, it finds the point where there is a best probability cutoff to separate the high versus the low risk. So this point, it actually maximizes the balance between the sensitivity and also specificity of the model. So the cutoff then can guide us to divide it to different risk categories, which we will see in following slides. So the data source for this methodology, the core data sets come from electronic health records, which provide the real-world clinical information, and it is also sourced from laboratory systems and the SRDP screening registry and also medication databases. So the population and sampling, the study population, we focus on type 2 diabetic patients who are followed up in the public healthcare settings in Singapore, and the sampling approach is consecutive sampling, meaning we include all patients who meet the eligibility criteria within the study period, and this helps reduce the selection bias because we are not selecting a small subset. We are taking everyone who qualifies. So the inclusion criteria are the patients are aged 18 years and above, and they don't have DR at the baseline during that fixed baseline period, which we set at January 2022 to December 2022. And exclusion criteria includes anyone with DR before the study period. That means they, for example, they are diabetic patients who may not have diabetic retinopathy now, but in their records they have been diagnosed years ago and were treated for it. So these patients will fit the exclusion criteria. And those with less than 1 year of follow-up are also excluded, and those missing crucial data such as HbA1c values are also excluded. So we excluded those with less than 1 year follow-up because we need enough time to observe the incidence, and also if the less than 1 year follow-up is excluded, we also exclude patients who might have already developed retinopathy during the baseline assessment, but maybe was not detected because it was very mild in nature. So next we go into the variables and features. Broadly, these include the demographic variables, clinical variables such as BP, BMI, smoking status, relevant laboratory results such as HbA1c, eGFR, which is the kidney function, treatment on board, which is the insulin, oral hypoglycemic agents, statins, and then we also have derived variables, which is HbA1c variability, which is will be feature engineering later, and outcome, which is the incident DR, which is yes or no. So before the model development, careful pre-processing is required to make the EHR data usable and reliable. So key steps include, first is the median imputation is done for any missing values, and if there are any duplicated erroneous records, we delete those particular entries, and that particular entries in its row entirely. And then we have continuous variables such as HbA1c or blood pressure readings. We have to normalize them for ease of interpretation by the machine learning model. And categorical variables such as medication status, gender, ethnicity, we encode them, one-hot encode them. And then feature engineering is done for certain features, such as, for example, the HbA1c. We calculate the HbA1c variability. We calculate the average HbA1c in the 12-month look-back period. So this slide summarizes how the three objectives connects to the model pipeline. So objective 1 feeds into the process by identifying key predictors through the statistical modeling and feature importance. Objective 2 is the core machine learning step, where we train the supervised models such as logistic regression, random forest, gradient boosting with XGBoost. And we train, like I explained before, we train and we split them into training and testing subsets, and then have five-fold cross-validation to optimize the hyperparameters, and then use metrics to evaluate the performance of these models. And then calibration assessment, we compare the predicted risk to the actual risk of the patients, and then feature importance analysis to identify the key predictors. Then objective 3, which is will be done at the end, which is risk score development, converting the predicted risk to a point-based score, stratifying into 3 tiers. So for example, the dummy table here shows, for example, if the patient was at a low risk, which is less than 10% of risk, we would advise routine screening, perhaps at a larger interval. If it's a moderate risk, 10 to 20%, we would advise for increased monitoring, and if it's at a high risk, more than 20%, it will be a priority referral. So ethical considerations, the mainstay of this study is using secondary EHR data. So there is a responsibility of protecting the patient privacy. This is done by de-identifying the EHR data, so we do not have any knowledge of who these patients are. Since this data is already collected and we are not using any active patients, there's no direct patient contact or intervention, so there is less risk of patient privacy concerns. And we will be using secure institutional servers and restricting access of the patient data. And finally, this study would need to be approved by the relevant institutional review board, and the data security and confidentiality would be maintained at all steps. So in summary, this study proposes a predictive EHR based approach to estimating the risk of diabetic retinopathy within a 1 to 3 year period among adults with type 2 diabetes in Singapore. So by identifying the key risk factors, developing a validated machine learning model, and translating predictions into actionable risk tiers, this research aims to support more targeted screening and efficient use of healthcare resources. Ultimately, the study hopes to have the potential to improve early detection and prevent vision loss through risk-based intervention. So these slides list the key references that I've used to inform the study design, methodology, and justification, including the literature on the epidemiology and machine learning in healthcare and risk-based screening strategies. Thank you very much.